So the title of the talk is really preventing COVID-19 in high-risk patients. We're going to look a little bit beyond just a standard vaccine talk that I just did one last night. We've been doing a lot of those over the last period of time. This is really looking at therapeutics that we have as a prevention strategy for individual patients and really looking at pre-exposure monoclonal antibodies for the patients who may not respond to the vaccines. And you'll see as we go through this one, this is a surprisingly large amount of Ontarian patients and a large amount of the patients that you may see within practice. And there's really an opportunity for pharmacists to step in with these new changes within scope that we're going to have Jen and Dr. Wachowski actually go through some of those components as well. So first off, my disclosures, I work with a variety of pharmaceutical manufacturers just for the work that I end up doing. I work with every vaccine company at one point or another. I'm being paid by OPA to be here this evening, as well as Jen Belcher here in her disclosures as well. So what are we going to cover? The goal here is really look at the indications and recommendations for tixagevimab and silgivimab. See, I tried once and I got it right. So I'm going to just call it Tixa and Silga from now on in preventing COVID-19 high-risk patients. Really looking at potential candidates for this therapeutics to prevent these infections and severe outcomes, potential adverse effects of some of the administration of it, and then really where the role of pharmacists are coming in recommending this in light of the new changes that have come up for the ministry. And this is really where we'll lean on Jen and we'll lean on Dr. Wachowski actually to provide you some of that impact as well. So it's always a good time to do a level set. Where are we today in terms of the pandemic? We've been talking about this for 3 years. What does it look like? And, I pulled some data over the last little while. So I have the pleasure of working multinational with a variety of different countries. So both within Europe, within the US, and within Canada. And we're awesome. Like if you look at the overall numbers, COVID-19 cases per million, which is what we see here on the left-hand side of the slide here. And you can see we have France, Germany, United Kingdom, United States, and you can see Canada. We have one of the lowest rates within these industrialized nations in terms of COVID-19 cases per million. And one of the reasons why, if you go on to the figure on the right, is that you can see right at the top, we have one of the highest amounts of COVID vaccine doses administered per 100 people. So we were really quite accepting of the COVID-19 vaccine in terms of the primary immunizations across the board in comparison to many these other countries that were there. But, that's good news. And you know what, anybody who's heard me present over the last little bit, I'm just like Debbie Downer over the last little while. So it's all about where we are. And, this is data that I pulled yesterday, looking at vaccine uptake and what we've seen not only here within Canada, but really every nation, US, UK, we've seen this in Germany as well. As we've introduced additional doses for patients in terms of vaccines, the uptake has been less. And this is one that NACI has published, and this is a new data point that they put out, is looking at patients, this is patients, every patient, but I pulled the data for over 18 years of age across Canada, it's been less than 6 months or haven't had a vaccine booster or finish a primary series within 6 months. This is really a crucial component. I don't have time to really cover it, and it's not really the focus of this individual talk, but we know that with the original monovalent boosters, the overall vaccine effectiveness of this one really started to wean over that period of time. And really 6 months out, this is where we start to see a lot more of those breakthrough cases, really showing the need for this fall reset that NACI's come up with the Ministry of Health in terms of bivalent booster recommendations as well. So really an opportunity. Only 1 out of 5 people in Canada actually have received a booster within the last 6 months or finished a primary series, really showing a need for us as pharmacists and other healthcare professionals to engage our patient population, to work with them to look at enhancing their overall protection. So Dr. Wachowski, this is your slide. I love it. Lots of stuff going on here. I wonder if you want to talk through some of the key points here of what we are like in Ontario, because I always say when I present it in other parts of the country, in Ontario, we're the center of the universe. Everybody wants to know about us. I think we should, but I'd love to hear what your thoughts here in terms of what are the key numbers you want pharmacists to focus on here on the slide.
Yeah, thanks, Mike. Of course, we're the center of the universe. So why would anyone think differently? And Toronto, the center of Ontario, it goes all the way down. So this is our provincial dashboards. We get daily updates on this thanks to the COVAX data system, and thanks to everybody for being comfortable using it. So that we can in live time show exactly what we're having in terms of our vaccine uptake across the province. And I'm just going to focus on the far side of the curve, which is just what we're seeing right now in terms of uptake. Obviously, we've moved on to, for most people, it's 4th or 5th doses at this point in terms of what boost you're seeing. But our overall uptake compared to the early heady days of the vaccine program is quite slow, very, very slow. So you can see our 7-dose average. This is as of last week. So it actually has gone up a little bit since last week. I didn't have a chance to pull the latest numbers. Is in the, there's about 25,000 doses a day that were going out compared to days in the beginning of the program where we'd had, we could have 100,000 doses a day across the province. It has gone up a bit. We're about 33,000 as of this week. And so that is getting better, and we are seeing some more interest in the vaccine, but it's very, very slow going, I think, is the key point here. Some interesting things are we are still getting first doses in people in tiny numbers. There are people still coming forward for first doses, which is wonderful to see. But really, if you look at our numbers of first and second dose uptake and then the drop to now fall booster, that's a pretty steep cliff from 91% people who have completed their primary series to 6% who have had a fall booster within since September 1st. And that's really the concern that we're having at this point as we get into the fall and as we're already starting to see cases start to rise.
Yeah, it's such an important point. 6% total, and this has been available. Now, how many weeks are we going at now since the bivalent was introduced in Ontario? It's been
about 5 weeks since the bivalent was introduced. So for almost 6 weeks now, and so in 6 weeks ahead, it's been slow going. Put it that way.
Yeah, it really indicates a huge opportunity for us. I know that's not the focus of this one, but it gives us an idea that if we don't probably do better with this one, if a new variant comes in, this could be a potential concern for many of the patients that we see in practice. And this is also, I know you have a lot of text here, but is there anything here you want to really highlight as well?
I'm meant to take this slide out entirely and use the picture. Okay. Did the picture one get in here?
No, the picture one I don't have. This is the one that I have.
Oh, no, sorry. I made the wrong one. Okay. We had a great picture that would have been lovely for everybody to see. And this is particularly for immunocompromised populations and high-risk populations, which is of particular relevance to the talk we're having today about the Evusheld product. The gist is that the dose coverage for our immunocompromised populations in particular is quite low across the province. So we have, depending on exactly what type of immunocompromise, so obviously we have ranging from those who have transplants, those who are undergoing cancer therapy, who are on chronic dialysis. We have pretty low coverage of third and fourth doses. Third dose is completely.
Look at that number though, 37.7. That's just a third of immunocompromised have received that dosing within the last 4 weeks.
Yeah, and that's just fourth dose coverage. You can look to the line right above, and that's just completing the primary series of 3 doses, only 60 to 80%. I didn't know you could do that spotlight. That's super cool. So really the emphasis of this is, even though the vaccines are great, we're not even getting the coverage that we need in vaccine uptake in these highest risk populations. So anything we can do, and I'll emphasize vaccine until the cows come home, and hope that everybody on the call does as well, and anything else that we can do to help provide additional protection to these populations is going to be of the most benefit to overall how we're managing the pandemic and managing our healthcare system capacity.
That's great. So what I'm hearing from you is the same things that we're hearing is not a great uptake in terms of our fall booster reset that we're talking for just in the general population. And even in our highest risk patients, the patients that are the highest risk of actually being hospitalized or severe outcomes, it's generally been pretty poor so far. We could do much better as a group. So an opportunity for all of us to work together to end up helping our individual patients as well. Thank you so much for that. I'm going to do a test for all of you moving forward. This is one infectious disease specialist that they've decided that they're going to map out all of Omicron. So you can see on the left-hand side, we have BA1 here, BA2, and then BA4, BA5 in terms of what the variants are component. And we're moving along. So we've gone from alpha, beta, gamma, delta, moving into Omicron. And we see now we have these subvariants, but we have now subvariants of subvariants as we move forward. So we have no idea really what's happening. I know that the ministry has actually released some data looking at BQ1, which is in BQ11, which is subvariants of looking at BA5 in terms of origins. But there's been a lot of talk about XBB, which is the Griffin one, and then talk about 275, BA275 and 2752. The interesting part is nobody really knows exactly what's going to end up happening moving forward in terms of the Omicron variants. I think there's going to be a lot. There's been talk that it may not be a dominant variant. We may end up having a variant soup moving forward. So really highlighting the protection. The good news is that these are all derived from Omicron, and we're hoping that the bivalent booster will offer us, clean protection against this for our patients moving forward. So lots happening here in terms of variants. So it's becoming increasingly confusing for patients as well as healthcare professionals. This was real world effectiveness data that was actually done within the Delta wave. So the numbers are a little bit different, but in general, prophylaxis strategy for our patients and looking at outcomes. If patients end up getting immunized, whether at this time it was with the mRNA vaccines or the viral vector vaccines, pretty much across the board for severe outcomes. Severe COVID-19 infection, hospitalization, admission, and death, all of those were significantly reduced. So we may not be as effective within the monovalent strategy before the bivalent boosters at reducing cases. We have breakthrough cases with Omicron. But in terms of severe outcomes, we were able to reduce that for many of our individual patients. The problem is that this is for the general population. And, I use this we did a CPHA webinar, but it's really that there's some patients that are left behind. And that's really what the focus is going to be today. It's really looking at those immunocompromised patients who may not optimally respond or respond as well as you or I do to the individual vaccines that we're administering to our individual patients. This is US data. It's looking at about 3% of our overall population, adult population, are immunocompromised, leading to an increase in vulnerability to COVID-19. This includes some of the blood cancers that you have. So this would be your CLLs, your MCL patients, active chemotherapy, transplant, dialysis, patients taking immunosuppressants. Immunosuppressants are a broad-based category. If you look at it moving forward, we have many of our patients who are MS patients, our RA patients, or all of our rheumatology patients that are using biologics. Same thing would apply for our plaque psoriasis, psoriatic arthritis, IBD patients. Many of those are taking immunosuppressive therapy, as well as patients with primary immune deficiency. So it's about 3 in 100 patients that are actually showing up in your practice on a regular basis. Lots going on with the slide, but I'm going to put some highlights here. Immunosuppressed here is looking at the overall vaccine effectiveness. This is UK data looking at 28 to 90 days post dose 1 versus dose 2. Older data that's here, but you can see within this group, the overall effectiveness of the patients who are immunosuppressed is lower than what we see for many other conditions that are across the board. And that's been consistent. We know that. We've known that for quite some time as well. A cool graph that's here, and it's looking at antibody response in patients who have immunocompromising conditions. What we look at is healthy controls is at 95 to 100%, and where do people actually rank comparison to a standard healthy control? Let's start with the good news. Patients on hemodialysis, you can see a lot of them are actually in that range, so it's not too bad. Immunosuppressive therapy, and I think that you're going to see it depends on the immunosuppressive therapy, and that will actually be some discussion that we have today as we look at who qualifies for Evusheld. And then some of the key concerns is if you look at cancers, light blue are regular cancers or just solid tumors. Hematological cancers are in dark blue. So you can see that hematological cancers do not necessarily respond as well to the antibody responses that we've seen. So it's an opportunity that's showing that some of the patients that you're seeing in practice, even though we dose them with terms, this is the 2-dose vaccine regimen, they were not responding in comparison to healthy controls. So if you think about it, well, what would you do? If they're not responding to 2, the first thing we would probably do is we look at, what if we give them 3? So that's the first thing. So if you look at patients who have response to the vaccine, so these are 3rd dose versus 2 doses, 2 doses and 3 doses. So you can see that the patients here are moving from a no of 57% to 53%. So a portion of these patients when we went to a 3-dose primary series. This is for kidney transplant patients. For CLL patients, so chronic lymphocytic leukemia, we went from 43% to 50% by doing this. So really highlight some of the strategies as we move for these immunocompromised of that additional dose to offer that protection. But as you heard from Dr. Warshawski, not all of our patients who are immunocompromised are not getting that 3rd dose or having completed that primary series. So that, I think it was 66 to 81% was that overall group. So still a big chunk of these patients are actually not getting that necessarily protection. And if they did get that protection, it likely was a while ago, really emphasizing the need for that booster dosing as well as other strategies. And that's what we're talking about today. Omicron has made a difference in terms of the overall, this is looking at antibody levels as well. 2 doses, 5 months after the 3rd dose, you can see the antibody protection levels here for BNT122B2, which is a short form for Pfizer. But essentially, you can see that after 5 months after the 3rd dose, the levels have dropped out quite a bit. In comparison to wild type, so D614G or Delta, the numbers are actually quite higher. Once we boosted with 1 week after the 4th dose and 2 weeks after, the numbers went up quite significantly for those patients. Same would apply for Moderna across the board. So it does work in terms of the overall protection, but what we've seen with Omicron, not only did the level of antibody level in terms of protection wasn't nearly as high, the half-life, it dropped off relatively quickly in comparison to other variants that we've seen in the past. So bivalent boosters, I don't want to spend a ton of time here. I love logarithmic scales. So, you look at these two, and Mike, look, there's no differences between them, but they're logs. One is 2372 and one is 7672. So this is looking at Moderna's bivalent boosters. This is the BA1 that we have currently available here in Ontario. They looked at third dose, what they measured 29 post-booster, looking at GMT levels. So basically antibody levels for these patients after that third dose at 29 days. You could see at third dose, 630, don't worry about the actual numbers. What we're looking is relative comparison. So if we boost 29 days after the fourth dose, you can see in seronegative patients, these are patients that never had COVID-19, we actually were able to increase Omicron protection up to 4 times that overall level. Whereas if you unfortunately ended up getting COVID, you actually went from 630 to 76, 72, so 12-fold higher, really indicating that when patients say, well, I had Omicron, I really don't need it. This is really showcasing that this is a great way to actually offer robust protection for these patients in terms of antibody levels. So something that you can recommend for those patients moving forward. So despite the vaccine, we're looking at the 2.7 or 3% of that population. They really, in the US, they made up about 40 to 44% of hospitalized patients with these breakthrough cases are immunocompromised. So really, they're the highest risk patient. They're not optimized in terms of booster dosing and in terms of primary series. So it's a really opportunity. And even if we give them perfect, so you saw with the numbers there when we moved to 3-dose primary series, about half were protected. The other half were not. And that's really the strategy why we're talking today about looking at monoclonal antibodies to end up helping these individuals from a prophylaxis basis. So from practice, to sum up that section, is really vaccines reduce the risk of severe outcomes. A portion of your patients don't respond well to them. Transplant patients, specifically some of the patients with hematological cancers as well, and some immunosuppressive therapies have poor response to the vaccines. Even additional doses, they do help. It does make a difference, but may not protect this specific population who are highly vulnerable. And my key concern is really, as we've opened up and we moved on, many of us have gone on to our regular lives. These are the patients that are left behind, but it's not just the patient themselves. So I would look at the standpoint, if I had an immunocompromised spouse or someone living with me, I would have to adjust my entire lifestyle associated with that so that we don't bring it home and introduce COVID to this really, really vulnerable population. So anything you can do is not only going to help the person that has these conditions, it's going to help the family around and anyone that they come in contact with. It buys them a level of confidence and a level of protection that we really want to give them. Okay, so let's talk a little bit about Evusheld. So it's Tixasilga. So, it's a combination of 2 monoclonal antibodies, and they go after unique sections in terms of the spike protein. It's a receptor binding domain, 2 unique sections that are there. It's potent. It has neutralizing activity against variants of concern, has an extended half-life, and it's one of the key things with antibodies is that usually very short term. This one, and they've been able to make it last for this period of time to actually offer that protection. And efficacy has been shown pre-exposure in high-risk populations. So one of the key questions that I always have come up, and I try to explain it, is, and this comes out with the vaccines as well, as the spike protein has continued to evolve as we move through different variants, is that, patients are coming up and saying, well, this is the new variant. We should have a new one to get that specific antibody against that spike protein. It's not one antibody that's generated by the body against the spike protein, it's multiple antibodies. So why I say that is that when patients will say, should I get a BA1 or should I get a BA4, BA5 vaccine? It really honestly is, we just want them to get an Omicron booster. It's going to offer them broader and a breadth of protection or in terms of antibodies that are generated specifically against Omicron. So looking at this basis, what is the mechanism of action? It's, you probably have heard this a gazillion times by now. Spike protein binds to the ACE2 receptor. It binds to the receptor binding domain. That's where it actually connects to that ACE2 receptor. That is actually one of the areas that doesn't change too much. Otherwise, it wouldn't bind to that ACE2 receptor. What we have here in terms of these 2 monoclonal antibodies, they actually target that individual area of the spike protein, attach and make it so they can't bind to that ACE2 receptor. So key properties of this one, they have 2 antibodies that are included with them. They have a synergy and they have high potency, have a half-life now from anywhere from ranging from 20 versus 70 to 100 days. So 70 to 100 days is what we have now. Maximizes the antibody location specific to this mucosa. And we have data from protection against variants. We're still learning some of the data in terms of where it's going to be for BA4, BA5. I haven't seen a ton of data that's been out there, but it looks like one of the letters to the editor that came out for the New England is that Tixa may not have a whole lot of protection against patients against BA5 specifically, but still end up maintaining that protection. So thus the combination was still quite effective in terms of the overall group, but it's still really, really early. So, but for this individual patient, it's not like we're doing for a broad population. It's really the highest risk individuals that may not have that full potency from what we've had in the past. Does it work? And the proven study was done, and this was done from AstraZeneca, put this together. It was 18 years of age in patients who had an inadequate response to vaccinations, negative SARS-CoV-2 tests, negative PCR tests at dosing. If they had a history of COVID, SARS or MERS, they weren't included. They've had prior vaccines or monoclonal antibodies or biologics for COVID, they weren't included. Randomization 2-to-1. They get a 300 milligram dose, and we'll talk about administration, but it's 150 milligram in one butt cheek and 150 milligrams of the other monoclonal antibody in the other butt cheek is what we ended up doing versus placebo. And then they looked at the primary endpoint as positive symptomatic illness. So we're looking at patients that are presenting with COVID-19. Kind of an interesting population. So 75% or more than 75% had comorbidities. So they were on immunosuppressive therapies, diabetes, obesity, cardiovascular disease, chronic obstructive pulmonary disease, chronic kidney disease, and we ended up having chronic liver disease within that population. The participants' age groups were less than 60 was 57%, greater than 60 being 43%, and in a mix of different ethnicities across the board, which was kind of nice to see as well. But that gives you an idea with this. If you look at this part of the study, a big chunk of these patients that we're trying to prevent are not those older adults, are a lot of those younger patients that may not even realize they're at elevated risk, except for the pharmacotherapy they're taking or their individual conditions. Did it work? Well, this is looking at the risk of symptomatic COVID and patients that got Tixa and Silga. Severe COVID was 0, death is 0, where in the placebo 5 ended up getting it and deaths were 2, for a relative risk reduction of 83% against symptomatic cases. And this was actually through 6 months of follow-up shown on this individual slide. And you can see the hockey, kind of the structure, it just kind of get that separation pretty much shortly after administration, and then just continue to go up in terms of the overall cases. So there is some data here that actually shows for this high-risk population, this seems to be working, and it's an effective strategy that we can use on top of immunization to help to protect those patients. Adverse effects, that's what all patients are kind of worried about, right? So adverse effects from this one, if we look at these, they're here are the ones that we would typically see when you're doing any type of injection. It gets kind of sore around the injection site. We have that for vaccines, we have that with this as well. Anaphylaxis was less than 0.1% is one patient that had it, or immune complex disorder, but generally pretty well tolerated in terms of overall adverse effects that we see. This was a preliminary trial that came out looking at specifically, does Tixa and Silga work in a vaccinated population during the Omicron surge? And this is breakthrough cases, and this was looking at Mass General data. And they said, yeah, it seems to look over that period of time that there was some separation in terms of the number of cases that we saw with Tixa and Silga versus control, as well as if we look at a broad base in terms of VA data that came out of the US, and this was published a little bit ago, immunocompromised population, you can see the separation again. So even during the Omicron phase, there was some protection that was seen, even though we've seen all of those mutations that I showed you on the initial slide, there was some data to support that. So to summarize for this section, this is such a great slide. It's really going through the key things that pharmacists are going to need to know. So what we do from a dosing, it's Tixa, 150 milligrams, Silga, 150 milligrams, 1 in each. I'm going to have Dr. Wachowski talk a little bit about when you would consider using a 600 milligrams, because that's actually within the monograph for prophylaxis, so 2 of each into the buttocks. Storage of this one, stored at room temperature for the duration of the product shelf life. Supplied in separate vials, we're not mixing them, that's why they're injected into different sites. As I mentioned too, it's disposable syringes. Separate IM injections, these are going to be gluteal injections that are administered, and there's no preservatives within this individual product. Okay, I'm going to turn it over to you, Dr. Wachowski. And I'd love to hear, like all of the things, I know you're going to go through some of the key things with the with what the ministry has in terms of their overall changes. And I'm pretty sure within your slides, I thought I saw something between the 300 milligrams and 600 milligrams. So I'd love to hear your thoughts. And just please let me know when you want me to move on the slides.
Yeah, for sure. Thanks so much, Mike. So yeah, I'm really trying to speak to this so everybody's aware of what's actually being involved in the rollout in Ontario of Evusheld in particular. So if you don't mind going to the next slide, Mike. We can go to the next one too. Okay, so this is what we've already gone through, but particularly just want to comment on the current clinical guidance that we have for Evusheld, which is from Ontario Health. that's been put out. So Ontario Health had a particular work group that was put together of experts in the field to speak to where Evusheld will be most useful for the Ontario specific population. Obviously, CADF had come out with recommendations nationally on which populations are high risk and should be considered, but very broad, and with some of the limitations in supply, particularly in the early days, it was necessary to look at who really should be getting it. So currently, the guidance in Ontario is specific about the use of Evusheld as pre-exposure prophylaxis. I'm not really going to talk about the treatment role of Evusheld, even though that Health Canada authorization just came through, I want to say 2 days ago, maybe 3 days ago. But so there isn't any Ontario recommendation specific on that now. So this will be focusing on pre-exposure prophylaxis. But again, there's guidance in Ontario which populations that is not to apply to. So next slide, please. And so this is the list for Ontario. So the initial populations that were eligible for Evusheld, starting from the very beginning of the rollout many, many months ago now, were primarily transplant patients, both solid organ and stem cell transplant patients, as well as those receiving CAR T therapy, and then patients undergoing treatment for hematologic malignancies, and specifically, obviously, immunocompromising treatments that would be placing them at increased risk. That's what our eligibility had been for the past several months. And just recently, earlier this month, it was expanded, given what we've been seeing in terms of new evidence around Evusheld and the protection for additional populations. And so those expanded populations include people receiving any anti-B cell therapy. So not only those receiving it for the purposes of chemotherapy, but we can think probably of many rheumatologic patients who would be covered from the same under the same category, and then patients with a primary immunodeficiency. And I think, again, in the guidance, we list a couple examples, but really anybody who has a significant primary immunodeficiency syndrome, where we know they aren't, number one, responding as well to vaccines as much as they could, and obviously at higher risk as well for severe disease from COVID-19 itself.
Yeah, I just want to call out here from in terms of solid organ transplant, the way like some of these are going to be hard for us to identify within the pharmacy practice. So some of the drugs that you want to be looking for is your tacrolimus patients, cyclosporin patients, high-dose corticosteroids for those individual patients. And the fortunate part is many of the transplant patients that I've taken care of over the years, all the scripts come from a transplant clinic. So you eventually get to identify these individuals. So you likely know these patients in practice. It's just starting to look for those drugs. Anything that I missed, Jen, from your standpoint?
No, I just say that as our role as immunizers within the COVID-19 program, we were seeing a lot of these patients for those extended primary series. And so having had those sorts of conversations with individuals around vaccination and the requirement to have, a 3-dose primary rather than a 2-dose, going back to those patient lists and determining if there are patients you can follow up with from there that meet these criteria, rather than just our standard look to dispensing profiles and using our pharmacy management system reports in order to identify people on specific therapies. Because as you mentioned, there are a significant number of these therapies that standard community pharmacies may not see, either due to specialty dispensing networks, therapies administered in hospital, or in other settings. So from that standpoint, really it is that knowledge of the patient and our role in the immunization campaign that can play into that patient identification process.
That's such a great point. Sorry, I didn't mean to interrupt you there, Dr. Warshawski.
No.
This is just from that identification standpoint. I love that point, Jen, about looking for the patients that are doing that multi-immunizations. But what I'm saying is that if we're not bringing it up to these patients, they may not even know that this option is even available. So it's really showcasing the need for pharmacists to step up and saying, listen, I saw that you got 3 of these. Can I ask you what type of condition you have or what your current treatments are? Because that can be we may have another option to look at overall protection for you. From that.
And Mike, maybe I just, shout out to the need for pharmacists to have access to those clinical viewers in consideration of signing up if you don't currently have access, because, views of the drug therapy as well as, the overall reporting and what have you that you can access through that clinical viewer. So I know OPA has done a lot of messaging communications in our professional practice updates. If there is anyone who needs help with how to sign up to that Ontario clinical viewer, please reach out to our practice support network at info@opatoday.com, and our team can assist you with how to proceed with that.
That's great. Thanks so much, Jen. Sorry, I just trying to make it as practical as possible, because I know some of my colleagues are going to say, how am I going to find out who these patients are? So
No, thank you for saying. And again, like with the attitudes we know people have towards COVID right now, even those who are significantly immunocompromised, we need all the expert clinical voices that people trust to be reaching out to patients as best they can. Whether it's physician, nurse, pharmacist, like everybody under the sun, like we need the multimodal approach if we really can get patients to get the protection that we think they need. So excellent points. Okay, so this is the kind of the nitty gritty in terms of how Evusheld is accessed in Ontario. So initially, given the very tight populations that were eligible starting at the rollout in May, it was really just through those particular hospital-based programs that Evusheld could be received. So we only had cancer and transplant patients, the only cancer and transplant programs that were directly giving out Evusheld. And so that had been successful when we had those particular populations as the ones who were able to receive it. However, again, with the expansion to those other populations who, yes, they may be associated with a specialist at a hospital, but are unlikely to be seeing them anywhere near as often as the other populations we had before. It really becomes necessary for them to be having outreach through other avenues. So in terms of the new dispensing process, basically, there's still a prescription that is required. So any physician and nurse practitioner can prescribe Evusheld for their patient if they meet the clinical criteria that we have gone through previously. And then dispensing is now available through pharmacies across the province. And Jen probably knows the number of pharmacies better than I do, and I'll leave it to you. But that's really the important part, is that we know that all of the community rheumatologists who are going to be prescribing for their patients, many are not associated with the hospital. It's not like they're picking up doses for their patients somewhere, so it's going to need to go through pharmacy to make sure that patients can actually get the doses they need. At this time, the injection still has to be done by the prescribing clinician. So they'll have to pick it up from the pharmacy and take it back to the provider who initially prescribed them the dose, so that the injection can occur. In terms of dispensation, this is your point earlier, Mike, about the 300 versus 600 milligram dose. There is additional guidance on what's recommended at this point in time for Ontario between those two dosing schedules. Obviously, the basis of that is the level of protection we're getting from Evusheld by different variant of concern that we're seeing. As we've moved into the BA.4/5s, there's been evidence that Evusheld has been slightly less effective, and that doubling the dose does restore a significant proportion of the protection that you're getting from the Evusheld product. It's highly variable guidance across the country, let's say, and Mike can probably speak to every province and territory's guidance on it right now. So in Ontario, what we've done is essentially presented the available evidence into the guidance that we have, and we're leaving it up to clinicians to decide what would be most appropriate for their individual patients. But with knowledge that the currently circulating strains in Ontario are more likely to get a better response with the higher dose product. But again, ultimately a clinical decision to be made. The additional details here about how the pharmacy dispensing works. So obviously there's the cold chain management that needs to be maintained to make sure these products are working well. And at this point in time, we're actually asking all of the clinicians who are administering the product to store the entry in the COVAX data system. So COVAX, everybody's very familiar from our COVID vaccines, but because we have an overall limited supply of this product, we're really trying to watch very closely who's getting it, how many people are getting it. So that's ultimately where we're liking to keep the data. The last piece I'll put here at the bottom is in terms of expanded pathways for Evusheld, which is still under work. But we're looking at expanding to additional prescribers, additional injectors, and additional sites to make sure that this can be more broadly available than what we have right now. Because obviously the easier it is for patients to access a product like this, the more likely we are to get uptake in such a high-risk patient population. Okay, so in terms of what we've done for Ontario so far, and Ontario has been overall, Mike, you can speak to probably better than I can as well. I think we've done reasonably in terms of getting Evusheld to patients who need it. So we've had just under 4,000 administrations of Evusheld via the hospital-based clinics to date, which is a pretty small percentage of that group who is actually eligible. And that's just the initially eligible population. So that cancer and transplant group is about 66,000 patients in Ontario. So we're hitting less than 10% of them right now. Obviously, there are clinical decisions in terms of whether somebody should be getting it or not, and so I can't speak to every individual patient, but I think some of the awareness of the product and utility, something we'd like to expand further to see if we can get protection expanded more broadly. Since October 3rd, which has not been that long, we've seen 15 prescriptions dispensed through pharmacies. There was a little bit of a slow start in terms of getting very clear information out to community providers how they were to actually order it. So I'm hoping that picks up, but it is at least started, and we know that things are moving forward. Okay, and this is the fun slide that I was talking about before. So this is, yeah, so we got it all here. We had it in words, we had it in pictures. You're getting everything you need. This is, again, just that look at the priority populations for vaccine coverage. And the top group is that immunocompromised group. This is the population who we're talking about who is eligible for Evusheld. You can see the numbers here much more clearly in terms of who has even gotten the vaccines. And it's not going great at this point anymore in terms of vaccine uptake. So we're doing everything we can to get the additional protection of these populations if possible. This one I just wanted to share, and sorry, I'm flipping a little bit back to vaccines instead of Evusheld, and I didn't mean to do that in the middle. But really, this is just to focus on the incredible role that pharmacy has had in the vaccine rollout to date. You can see here, so the slightly darker blue in the middle, where the big numbers are, that's the percentage of administration of COVID vaccine doses that has gone through the pharmacy channel as opposed to any other channel. So pharmacy administered about 45% of all of the doses to date this is for September data that we have here. It varies hugely by public health units. Obviously, there's the distribution of actual pharmacy sites across the province, which makes a difference to what's available. But we have places like starting in Waterloo where 65% of fall boosters right now are going through pharmacy, which is incredible, down to Porcupine, which is only 10%. My real point here was reach out to your local public health unit. And see if you can be further involved in the vaccine program in addition to the Evusheld program, because we know that patients are very comfortable coming to pharmacy, particularly those who are highest risk, who trust their pharmacists with their medications and seeing you quite regularly. So please, 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 if you have the opportunity, get vaccine and get into those high-risk patients. So next steps, and so this is just a quick summary in terms of where we're at for the vaccine and Evusheld. So continue to order the products. They're available, and we do want these patients to be getting them, particularly for these high-risk patients in terms of vaccine. We're recommending the 3-month dose interval, so it'd be great if that could be recommended to anybody that you do see. And bivalent is the product of choice at this point in time. Monovalent is really, really only for primary series or children under the age of 12 eligible for boosters. Sorry, that's my bad in not being clear on which slides are about Evusheld and which are about vaccine, so sorry about that.
That's great. So Jen, do you want to talk about pharmacy operations? This is your specialty. I'm so glad you're here for this.
Sure. So, I know we've, done sort of the rapid fire coverage of the clinical aspects and really, what pharmacists need to know in terms of the role of Evusheld in preventing COVID-19 and infections. But, where the rubber hits the road is ensuring that pharmacy professionals know the ins and outs of how to get access, what you need to do if a prescription shows up on your doorstep, in your fax inbox, or so forth. So I kind of did a bit of a Q&A on some of the frequently asked questions that we see in the executive officer notices that were circulated on October 3rd to your one mail inbox. If your pharmacy doesn't have access to your one mail, those documents are also available on the Ministry of Health's website on the executive officer communications landing page from October 3rd. So you can do a quick search on that page for Evusheld, and I believe they're probably the most recent EOs that have come out as well. So you'll be able to access those two documents, both the sort of frequently asked questions as well as the guidance document there in both English and French. So, sort of the most pressing question is, okay, I have a prescription. Now, how do I procure the product? And any pharmacy who is able to bill online through the HNS to the Ontario Drug Benefit Program is able to dispense the Evusheld product. There are no specific requirements to sign up to dispense Evusheld. The only stipulations are that you must have a distribution account with either Shoppers Drug Mart Distribution Center or McKesson Canada. So similar to the vaccine program, there are no other distributors that are participating in the distribution of publicly funded Evusheld through this program, though you may be able to find the drug listed privately on alternative distributors. those products are not eligible for reimbursement through this program for eligible Ontarians. So just ensure that when you're ordering the publicly funded products through those distribution centers. And in doing so through that program, you do not have to pay for the drug cost of Evusheld. So you will not be charged by wholesaler for drug costs or any associated markups. However, you will be charged a distribution fee when ordering the product. That distribution fee will be reimbursed as a professional fee on dispensing of Evusheld, but it's just something to be aware of, that as you are going through your invoices and doing any sort of payment reconciliation, that you will incur some charge for Evusheld, but that will be reimbursed on dispensing, and it's not for the drug cost itself. It's solely to cover the distribution of the product through the wholesalers. Next slide, please. So in talking about reimbursing the professional fee as well as the distribution fee, how do I bill for Evusheld and how much will I be reimbursed? So important on this slide is that there are two pins. One is associated with the 300 milligram dose of Evusheld, and the other is the 600 milligram dose. And so it's very important that pharmacies use the correct pin pursuant to the prescription that you receive. So if you receive a prescription for the 600 milligram product, you cannot claim two of the 300 milligram pins. So it's important that you choose the correct pin in order to receive the correct fee for the dispensing and distribution costs of the units. So total net payable for a 300 milligram dose is the $23.25, and 600 milligram dose is $33.25, and that difference is the distribution cost on 2 units of Evusheld rather than 1, because what you will receive are 4 vials for a 600 milligram dose rather than the 2 vials for 300. The professional fee for the dispensing is $13.25. So when you add those all together, those are the total amounts payable on the claims. And pharmacy dispensing softwares should have updated drug cards for the online billing of these products using those pins. So we can go to the next slide. So does a patient need to be an ODB eligible recipient or have an Ontario health card in order to receive Evusheld through the publicly funded program? So no, any patients who live, work, or study in Ontario or who are visiting Ontario from another province or territory or country are eligible, providing that they meet the clinical and demographic criteria. So Dr. Wachowski covered off the different clinical criteria. Just important to note from a demographic perspective that patients must be 12 years of age or older and weigh at least 40 kilograms. And not have an active COVID-19 infection or be a recent close contact. I believe it's within 8 days of a high-risk contact of a COVID-positive individual. And if a patient does not have an Ontario health card, how do I bill for the product? So similar to other COVID-related services, if a patient does not have a valid Ontario health card but is eligible for the service, the HNS has a proxy patient ID of 7, a bunch of 9s ending in a 3 that you can enter into the patient's profile under the Ontario Drug Benefit Plan using the patient's proper demographic information like name, date of birth, and so forth in order to bill the claim. If you use a pharmacy management system that requires intervention codes to be entered manually and not automatically for this drug card, you do need to use the PS intervention code in order to have the claim processed as a professional service. Next slide, please. Mike covered this off on how Evusheld is stored because it is a refrigerated product. So maintenance of cold chain throughout the dispensing process is important in order to ensure the integrity of the product. I mentioned in the demographic piece that they need to be COVID-19 negative and not have recent high-risk exposure. So do they need to have a negative COVID-19 test prior to dispensing, and do they need to demonstrate or show that in order to receive the product? So the answer to that is no. Pharmacies do not have to verify a negative rapid antigen or PCR test in order to dispense. However, patients should be screened for symptoms of COVID-19 prior to administration and be screened for high-risk contact with the positive individual. Next slide, please. So here's one. Can I administer the Evusheld injections in the pharmacy? We've talked about them being gluteal intramuscular injections. And the answer to that currently is no. So pharmacy professionals do not currently have the scope of practice to administer Evusheld by injection. So in these cases, patients should be referred back to the prescriber who's issued that prescription in order to receive the injection. However, in cases where a patient received the prescription virtually, subject to other similar delegatable acts, pharmacists could collaborate with prescribers and provide the injection services should they be injection certified under something like a direct order pursuant to all of the regulatory requirements and parameters around delegation of authority. But currently, the administration of Evusheld, similar to other injectable medications that are not covered under our injection scope of practice, would mean that administering Evusheld within the pharmacy is out of scope. On the administration piece, as Mike had mentioned, there are two separate injections of each medication into each gluteal muscle. And in the case of the higher dose, they are just still two injections, just double the volume. I believe the 300 milligram dose, you're looking at a 1.5 milliliter injection in each side versus the 3 milliliter on each side for the 600 milligram dose. And do I need any special training in order to dispense Evusheld? So similar to how there are no restrictions on the pharmacies that can dispense this product, Evusheld can be dispensed by any Part A pharmacist or registered pharmacy student or intern under the supervision of a pharmacist in Ontario, pursuant to a prescription. So in that sense, of course, with the dispensing, all record keeping that is required of pharmacies and pharmacy professionals in the dispensing of prescription pursuant to the college's regulations would need to be followed and maintained in order to dispense Evusheld. Next slide. All right. So, given that many of us are active participants in the vaccine program, what about people looking for co-administration? I'm going to come in, I'm going to get my COVID-19 vaccine, and I'm an eligible individual. Can I get Evusheld at the same time? So the answer in this case is no, but if an individual has received a COVID-19 vaccine, Evusheld should be held for at least 2 weeks after vaccination. And if the patient is currently eligible for a vaccine dose, they should receive the vaccine before receiving Evusheld. So in this case, as we've talked about the relatively suboptimal numbers, if we're going to use a euphemism for our third dose and fall booster numbers in this population, our recommendations as pharmacy professionals should be twofold here, and that would be to receive their vaccine and prioritize that as your first act. And then after 2 weeks, they could receive the Evusheld administration in order to ensure optimal protection in this immunocompromised and vulnerable group. So we don't currently have any data regarding COVID-19 vaccination after Evusheld administration. So in these cases where we're looking to optimize the boosting of individuals with vaccine, it is ideal that we receive those doses prior to the administration of Evusheld. And I guess just from a practical standpoint, as we've talked about the identification of some of these eligible individuals, and I didn't do a slide for this, but should a pharmacist identify, or a pharmacy team member identify an eligible individual and look to have the pharmacist make a recommendation for Evusheld therapy to the prescriber, if that individual is an ODB eligible recipient, that recommendation to initiate Evusheld therapy would be fundable as a pharmaceutical opinion, that therapy is indicated. So in that case, should you be identifying patients and sending off those recommendations, once a response is received from the prescriber, pharmacists could bill for pharmaceutical opinion in the identification of eligible individuals. And I think that concludes most of my FAQs on the pharmacy operations side. So maybe, Mike, I'll turn it back to you for our key learnings.
That's great. So just to finish up, I know we're getting low on time. We've been trying to answer the questions in the chat that have come in. So to find out, it's really, as you've seen here, we have really at a gap, not only for all of our patients, but these immunocompromised patients in terms of COVID-19 vaccines. Really want to stress on the importance of working together as a team with everyone, family docs, primary care nurses, pharmacists, to really try to increase bivalent uptake as we move forward. Even with immunization, many immunocompromised patients are still at high risk, and these are patients at high risk of severe COVID-19. These are the patients that you do see in practice, about 3% of the individual populations, as we showed. Evusheld or Tixacilga is a long-acting monoclonal antibody combinations reduce the COVID-19 risk in these patients, and it's just another option that can provide additional layers of protection for our most vulnerable patients. In terms of some of the slides here that I have, does it replace the need for vaccines? These are some of the questions that we had in the past, and it's no, these patients may ask you that question. They would still need to maintain or have their vaccines prior to this one, as Jen has actually covered. Still require the additional boosters. So as Jen has covered, actually this exact same question, so I'm not going to go through it. Who should the medication be considered? And this was a question that we posed to an infectious disease doctor on this one, and his thoughts with this one is really anybody that's going to be at high risk of outcomes. So I think the criteria will continue to change. So as Dr. Wachowski said, this is the criteria in Ontario. And the criteria in each one of the individual provinces is slightly different. I think it's as we see what's happening with the virus as we move forward, the recommendations for where we end up using this is going to continue to change. The good thing about it is that Ontario will keep you informed, so you don't need to worry about what's happening in Manitoba or Saskatchewan. It's really what's happening here from that standpoint. I think that's like the rest of the questions I think we've all actually addressed. Efficacy against Omicron subvariant, we know it's reduced from that basis. It will continue to change as we see these new variants that are coming out. We do have some preliminary data, but again, when we look on population levels, we'll probably see more of that data moving forward. And how fast does it protect is a really good question that comes out. And the way that I describe it is that if we look at when we're using mRNA vaccines, is that we're actually providing instructions to our patients, or when we inject, we're providing instructions to our body to make spike protein. Thus, this is leading to the protection. It takes usually about 2 weeks for that full effect. We're actually injecting preformed monoclonal antibodies. They're already pre-made. So if they give it a pre-made formula, it's the same thing. We're injecting these. So the protection, as you saw with the proven data, was fairly quick right after those injections. So one of the reasons why we typically would want to administer this one shortly afterwards. I think those are my pre-questions. I think we've got almost everything else.
Yeah, I'd just say, in the Ontario, keeping informed, key areas to watch for updated information would obviously be your one mail inbox for things like executive officer communications. But many of you, if not all of you that are here today, are like the OPA members. So all of this content with additional clinical updates and other important information on these topics are covered in our professional practice updates, which are issued bi-weekly on Wednesday. Our last one was just this Wednesday. So if you missed it or haven't opened it yet, I'd recommend going and checking it out. And of course, if you have any specific practice questions as an OPA member, one of our benefits is that practice support network that you can access through emailing info@opatoday.com, and you'll be responded to by one of our pharmacy practice advisors.
And just a quick question for Dr. Wachowski. In terms of, I remember you saying the dosing, whether it was the 600 milligrams or the 300 milligrams, was strictly clinical decision. So a question that's been posed here within the Q&A is, what dose would you suggest for a patient who is using rituximab for non-oncological indication, whether it's nephrologic or GI? It's strictly down to clinical decision, and again, efficacy against the overall virus. So as we have that component, as these variants continue to circulate, we will probably have some various, but currently it's one of those doses is based on that clinical decision basis as well.
Exactly.
I'll
just add. Oops, sorry.
Go ahead.
I was going to say, I'll just add again, the data shows that higher dose is probably the one that's going to be better off. If you look at the CDC recommendations and FDA, I should say, like they're suggesting the 300 dose based on currently circulating variants. Leaving up to the clinician to decide. Okay. Officially.
There was a question in our Q&A around the use of bivalent vaccines as part of a primary series, asking in the context of hemodialysis patients who not completed 3-dose primary, and bivalent is only offered in the unit, and patient may not want to go into the community to receive monovalent as part of that primary series.
Yeah, that's a great question. I'd love to get your input on this as well, Mike. So obviously we don't have any direct data on the bivalent being used as part of a primary series. So it's a big question. We do have data showing that Moderna is probably the better product to use in immunocompromised populations, including hemodialysis patients. And the Moderna primary series monovalent is 100 microgram dose, which is significantly more than the bivalent product that is available. Again, we're not comparing apples to apples here, so it's hard to say for sure, but we all know how much better the high dose flu is to the regular flu. Even if it's trivalent high dose flu, we still recommend that over a quadrivalent regular. So I think it's a good question of what's really going to give the best possible immune response. And again, we just don't know for sure. So at this point, I'd still be recommending completing that primary series, preferably with the Moderna 100 microgram product for any of these populations, and then getting the bivalent afterwards. If someone were to receive the bivalent, would that be considered a valid dose in completing the series? Yep, I wouldn't have any problem with that either. And realistically, as long as they're getting something at this point in time, it's going to give them really good protection. The last consideration is, of course, that the bivalents aren't technically authorized by Health Canada for use as a primary series, which complicates things slightly further. So best advice would be try to complete it with one of the monovalent products at this time.
Yeah. The only thing I have to add to that is that there is zero data. Everything in terms of what Pfizer has done, and really specific Moderna, actually, both Pfizer and Moderna studied their BA1 and their monovalent Omicron in patients that had actually received original BN.2.162b2 or mRNA-1273, the original vaccines. These were only given as boosters. There is really little data. So the level of protection that we can actually say to our patients, we have no idea. So I'm a little bit skeptical when we were asked that question before, is why aren't they doing it for primary series? That's not the focus. A primary series is getting patients up to a certain point, and then the monovalent is moving them past that point to protect them moving forward. And that's one of the key things from a public health. We had some clinicians that had come up and said, telling patients everything you did before with all the booster doses and the doses you got, they're all useless now against Omicron. You need to get this new bivalent booster. It's kind of the worst thing you can say to patients. The best things you could actually say to patients is like, you primed it. Now we've updated the technologies, just like we moved from an iPhone 8 to an iPhone 14. This is going to be the new and latest and greatest that's going to actually offer you that protection. It builds on what we've done in the past, and that's why that primary series of the original vaccines, and this is boosting up what we have in that original basis or enhancing that protection.
I guess, Mike, that kind of speaks to a bit of the other question we have in the Q&A here around the selection of product for any of the boosters. And, is there any, compelling reason to continue to use the monovalent, if people hadn't been adequately boosted, or should we be only using bivalent for any booster doses past that primary series from here on out?
I've been really happy with the way the CDC did it in the US. So the CDC, and, you see some of the terminology that Dr. Wachowski showed here, it's a fall booster reset. So regardless of where you were before, we're resetting the strategy. Did you have two primary series, 2 booster doses, 2 primary series vaccine doses, and then 1 booster? It doesn't matter. If you've completed the primary series, this is the time to get the bivalent booster. We need the protection, not waiting. We need the protection today for these patients. If the virus is still circulating at the levels that we're having it, these are the patients we need to protect now, especially our high-risk patients, not only immunocompromised, or our patients that we're talking about in this webinar, but our elderly patients, our patients with cardiovascular disease, cardiometabolic disease, patients with chronic kidney disease. We want to ensure that they're protected against this infection. So really, as soon as you can get them protected, I would get them that dosing in if they're eligible for it as well.
Good. And I actually kind of came up with one of my own questions, which I will answer. Just thinking from an operational standpoint, I know Dr. Wachowski, you'd mentioned that prescribers are being required to enter Evusheld into Covaxon, and that is not a requirement to document in Covaxon for pharmacies that are dispensing. That responsibility is not part of the dispensing process for Evusheld and would reside with the prescriber. So just to have for people to keep in mind that though this will be recorded through that provincial database, that task is not currently being assigned to the pharmacy provider within the dispensing and procurement process.
And I have one question for both of you. One of the things that you said, Dr. Wachowski, on this call was whoever prescribed it has to administer it. So if it is an oncologist that prescribes it, but it's a patient or say transplant, and the patient lives in Sudbury, and the transplant clinic is downtown Toronto. Could they actually get it dispensed in Sudbury and actually have it done by their family physician within Sudbury and not the physician that prescribed it?
They could. Again, this is something that you have to have good communication between the prescribing and then administering clinician, whoever it is. Obviously, patients don't need to drive back and forth multiple times from Sudbury to Toronto if they don't have to. The preference is, though, that the prescribing clinician is the one to administer it because they are the ones who prescribed it in the first place. And it's really ideal if possible. But no, any clinician at this point who is one of the responsible clinicians for that patient would be able to do the administration as long as it's part of the circle of care.
Yeah, that's an important point. So I think what I hear from you is that if you're really living outside of the GTA area and you have patients that are candidate for you, you may need to be working with your family physicians there if you don't have access to the specialists that they see. So transplant physicians that are in Toronto, if they live outside of the spaces, the problem is that many family physicians may not necessarily heard about this option. So pharmacists, there may be some burden upon you to actually do a little bit of explanation of why this is important, and maybe look at working with the transplant clinic or the oncology clinic to work with a family doctor to look at that administration dosing so to ensure that those patients are protected. I don't have anything else. I want to thank everybody for joining us tonight. It's great to see this turnout. It's a really important topic for me. I really want to make sure that these patients are protected. I just don't want to see any more people that are going to be harmed by this virus, especially in terms of this overall group. I want to thank Jen for sharing her expert insight, Daniel Wachowski for actually sharing his expert insight. Hopefully you found this valuable. Good luck with all the stuff that you guys have been doing. I'm thrilled at what pharmacists have been able to do during the pandemic in terms of helping to protect our patients and maintain the quality of the care they need during the entire pandemic. And to that point, I'll turn it back to you, Jen.
Awesome. So I want to thank everybody for their participation tonight. I think I mentioned multiple times, if you do have any questions specific to Evusheld or any of the pharmacy programs, please reach out to our practice support network. Thank you to all the pharmacy professionals for the role that you have played in the prevention and treatment of COVID-19, both through the immunization program, the dispensing of therapeutics such as Paxlovid, and now Evusheld. We are all extraordinarily grateful for your role, and I wish you all a successful influenza immunization season, and may it be full of co-administrations, and we look to curtail this eighth wave. So I hope everyone has a wonderful afternoon and stay safe.
Thanks, everyone.
Thanks so much. Take care.